I'd like to thank John and Lena for inviting me. My disclosure is that I have no disclosures other than the fact that I'm a gastroenterologist. And I'm going to talk about complications of ERCP. This is a whole session unto itself, and to talk about the complications of ERCP in 10 minutes and do it justice is really difficult, so I'm going to concentrate a lot on perforation. But these are the complications, we all know them: acute pancreatitis, bleeding, infection, perforation, anesthesia mishaps, and others, cardiovascular events, power goes out, patient falls off the x-ray table. I had a patient crush his thumb in the x-ray gantry one time. These things happen. We'll talk about the common ones. We'll use the 5 R's, what I call the 5 R's of managing endoscopic complications, and I'll illustrate these 5 R's with a perforation case ultimately. Pancreatitis is the most common complication, and it occurs anywhere from 2.5% to 10% of ERCPs, and the risk factors are listed here: inexperienced operators, suspected sphincter of OD dysfunction as the indication, female gender, age less than 30, normal diameter bile duct, prior pancreatitis, and repeated pancreatic injection or cannulation. Needle knife pre-cut papillotomy is felt to be a risk factor, but most of us who actually do this feel that if you need to resort to the needle knife, that just means it was a difficult cannulation, and the needle knife itself probably is not responsible. Back in '91, Peter Cotton and Glenn Lehman published their consensus criteria on how to define what post-ERCP pancreatitis was, because there were a lot of publications out there that didn't even really agree on what it meant to have post-ERCP pancreatitis. So they postulated that you had to have an elevation in the serum amylase or lipase greater than 3 times the upper limit of normal. It's common for the lipase or the amylase to go up after sphincterotomy because you're pouring lipase-rich fluid right on top of an open cut, and you'll reabsorb some. So it has to be at least 3 times. The patient needs to stay in the hospital either for an unplanned admission or a longer than planned admission, and these things have to occur 24 hours after the procedure to make mild pancreatitis. If it's moderate, they stay in 4 to 10 days, and severe pancreatitis is defined as greater than a 10-day hospital stay, or patients who require other interventions such as IR drainage or who have a pseudocyst or bleeding or what have you. You all know how to treat pancreatitis, and this is a perfect opportunity for me to save a minute or two and just not talk about it. Fluids, narcotics, bowel arrest, and that's how it goes. And you guys know all this stuff. I'm not going to insult your intelligence by going over that. Let's talk briefly about bleeding. Post-sphincterotomy bleeding is not that common. It's about 1 to 2 or 3% of patients. Obviously, the risk factors are things like coagulopathy, antiplatelet agents, things of that sort. There's immediate bleeding and there's delayed bleeding. In the immediate setting, you obviously know the patient's bleeding. You have to finish your sphincterotomy. There's a dorsal or there's a superior arteriole that crosses the upper aspect of the major papilla, and it's common to lacerate this as you're cutting, and it's when you see a burst of blood in your visual field, it's very tempting to stop cutting. But you want to transect this vessel so that muscular contraction will cause it to retract and pull away and spasm down. Otherwise, it's much more difficult to control the bleeding. And then what I like to do is we almost always do a sphincterotomy with wire guidance, so there's already a wire in the bile duct. Throw a stone extraction balloon over the wire, inflate it, wedge it at the bottom, and pull your scope and your balloon together and tamponade the bleeding. And this is highly effective. The worst thing about this is waiting, because you just want to keep checking. Did they stop? Did they stop? Did they stop? Go out, have a sandwich, have a martini. And then come back and look in 5 minutes, and oftentimes the bleeding is stopped. You can infiltrate dilute epinephrine directly with the papillotome by jamming it into the cut edges and injecting just like contrast. Anyone who's ever had a submucosal injection of contrast knows it's very easy to inject after you've had a sphincterotomy. So you can infiltrate it with the papillotome and not even change devices. You can inject epinephrine with a sclerotherapy needle, or you can use the standard cautery devices that were talked about earlier. And then there's also delayed bleeding, just like in polypectomy. The initial bleeding, the highest risk period is in 24 to 48 hours. But afterwards, there's a bimodal distribution, and the risk goes up again at 7 to 10 days, and I've seen it out as long as 3 weeks. Other complications, the one I want to really harp on is what my GI colleagues often don't do, is they don't pay proper attention to surgical paradigms, you have to drain the infection. If you take out 6 stones and there was a 7th stone that you missed and it's jammed in the ampulla and it's causing cholangitis, you have to go back in and place a stent or remove that stone. A lot of times my colleagues will just put them on antibiotics and hope for the best, and that's not the answer. You have to drain in addition to antibiotics. So let's talk about perforation, and I'll use my model of the 5 R's. So this is a real case. I did not make this up. I was referred a 38-year-old woman from another gastroenterologist who had a history of fibromyalgia and anxiety, and I should have quit right there. But she had suspected sphincter of Oddi stenosis because she had typical biliary pain and a dilated bile duct on imaging. She was already on oxycodone and Ativan, and again, I should have quit right there, but I didn't. And then I found out at the office meeting that she was a practicing malpractice attorney who did not like to take cases for the defense. She only took plaintiff cases. So with all that being said and done, being cavalier, I decided to proceed. And this is the SCOUT film. And initially, we cannulated and injected the pancreatic duct, as we always do. It seems like, you always get the duct you don't want. And then we got a little contrast into the bile duct, and you can see that there's going to be a long biliary sphincter, and it's going to require a long, kind of a deep sphincterotomy. And as we get more contrast in here and get the wire up, the bile duct is dilated to about 9 or 10 millimeters, and which the radiologist will tell you is common after cholecystectomy, and I will tell you is abnormal after cholecystectomy, because radiologists only see patients who have pain after their cholecystectomy. They never see people who never come back, who don't dilate their bile ducts. But anyway, we started to cut, and lo and behold, we see this. If you take nothing home from this talk, remember what this looks like. This wedge-shaped defect of air in the retroperitoneum is what an acute retroperitoneal perforation looks like. It doesn't go further than partway, say, the mid-axillary line, because it's contained in the retroperitoneum. If it's a free intra-abdominal perf, the air will be everywhere. And the superior border is the back side of the undersurface of the liver, and the medial aspect is the right psoas muscle. So what do? So the answer is you recognize. The first R is you have to recognize that you've made a defect. And if you don't remember it, remember what this looks like. If you see this, you know you've perforated. You have to recognize it. If you fail to recognize it, you're going to have problems. The next thing you have to do is react. Don't just panic, react. You have to do something to fix this. What can you do? Well, in our case, we put in a nasobiliary drain. And the reason to put a nasobiliary drain in is twofold. One is you can inject contrast through it and see how bad the leak is, and you can divert the bile flow primarily. If you divert the bile flow, you will prevent all that bile leaking into the retroperitoneum. It's the bile that causes the pain. It's not duodenal contents that leak. And you can also pull tension on the nasobiliary drain. And if you look at this, it actually pulls the bile duct over and up, and it seals the leak when you pull tension on it. So I like to use a nasobiliary drain. If you're not familiar with placing them and you haven't used them, you can use a fully coated metal stent, which I'll show you in a moment. The risk factors for post-sphincterotomy perforation are small papilla, suspected SOD, advanced age, although all my perforations are always in young people, I don't know why, and large stones. I will show you one at the end, though, that was an older fellow. You have to have a high index of suspicion, and you have to have prompt recognition of that wedge-shaped lucency under the liver and the retroperitoneal emphysema. Divert the bile flow. At least place an NG tube. If you can place a nasoduodenal tube, so much the better. If you can divert the bile flow with a metal stent or with a nasobiliary drain, that's the best treatment. And then follow them clinically. Additional imaging is not helpful. And if you send this patient for a CT or an upper GI series, the contrast will run right into the duodenum, will go right by the cut. You'll be given a false sense of security, and then when you feed them, it's a disaster. The third R is reach out or request help. So what I did in this patient is I consulted the surgical chief resident on call. I specifically asked her, do not call your attending. This patient's on my service. I don't have residents. I didn't have fellows at the time. And I said, I just want somebody to eyeball the patient. Send the intern if you must, but I just want somebody to eyeball this patient tonight. Make sure she's not septic, tachycardic, has a SIRS response. And the patient actually did very well with just a nasobiliary drain. She spent 1 day NPO, and she tortured me with, I want to eat, I want to go home, I want to eat, I want to go home. Finally, on post-procedure day 2, we revisit. That's the fourth R. We revisit the injury. And in this case, the nasobiliary drain had slipped down a little bit. I took her to fluoroscopy and injected contrast, and lo and behold, you can see that the nasal biliary drain is still pulling the bile duct over and up, and as we inject contrast under pressure, none of that leaks into the peritoneum, so the leak is closed. I fed the patient and discharged her on post-op day 2, much to my consternation, but she insisted on leaving. And then the 5th R is repent. If you have a complication, especially pancreatitis, the patient's in the OR 5 times, they're in the ICU, they pull out their ET tube to yell at you. You need to see them every day. It's the most painful thing we do as clinicians, is to go see the patient, say, I'm sorry this happened to you. The people that I've seen that get sued for post-ERCP problems are the ones that abandon their patients and they don't go and see them every day. And if you go see them and tell them that you haven't abandoned them, it's better. I'll just leave you with a couple of other photos. This was a 91-year-old veteran who had a common duct stone on MRCP and had biliary pancreatitis. And he had to have a needle knife pre-cut. It was a difficult cannulation. And again, you can see the wedge-shaped lucency here, an obvious large retroperitoneal perf. And what we did is we gained cannulation of the bile duct, injected contrast. You can see it. We put in a fully coated wall flex stent. And you can see here where the waste is on the stent, it seals the leak and causes the bile flow to be diverted. There was some extravasation of contrast prior. You can see his little stone stuck behind the stent here. But this leak sealed, and that patient went home at day 5, and the only reason he spent 5 days in the hospital is he had urinary retention, and we couldn't find a skilled nursing facility for him. So again, maybe you should rejoice. That's the 6th R. When you finally discharge them, you rejoice. But the 5 R's, again, are recognize the problem, react to it, reach out for help. If you're not familiar with these things, it helps to have someone guide you through it. Revisit the injury, make sure you've done everything you can, and then repent. And that's all I have. Thank you.